Hello everybody, my name is Manuela Stoicescu. I am consultant internal medicine physician, PhD, assistant professor of University of Oradea, Faculty of Medicine and Pharmacy, Medical Disciplines Department, Romanian. Before I start my presentation, I want to thank you very much, committee organizing, especially Mr. Raul Wilson, for the invitation as a speaker at this important conference in field of cardiology in Barcelona, Spain. Now, follow to present my original topic for you, the cause of a young patient with third-degree IV block. The most important objective of this presentation is to find the real cause of a young patient with third-degree IV block. I will present the situation of a young patient, 27 years old, which presented a syncope, and the heart rate was really very low, 30 beats per minute, a very severe bradycardia, and the value of blood pressure was in normal range, 130 per 80 millimeter mercury. In the next slide, we can see together very good how show the ECG of the patient with severe bradycardia, 30 beats per minute, in context of the third-degree IV block. This is the ECG of the patient, and here we can see one P wave unconducted and the second P wave unconducted, and then once again a P wave unconducted, another P wave unconducted, and here again a P wave unconducted and another P wave unconducted. In the next slide, I will put a close image of the ECG to can see better the phenomenon. And here we can see indicate with these two blue arrows the P wave unconducted and another P wave unconducted, and then once again P wave unconducted, and here another P wave unconducted. So in conclusion, on the ECG exists a complete third-degree IV block. Third-degree IV block, also known as complete heart block, represents the situation when the impulse from the sinoatrial node, from the atrium of the heart, does not propagate to the ventricle because exists a complete block at this level at the atrioventricular node. Because of this phenomenon, the P waves will be with a regular interval, P to P interval. In other words, a sinus rhythm represents the first rhythm of the patient, and the QRS complexes with a regular air-to-air interval present the second rhythm of the patient. In fact, the atriums and the ventricles contracted independently, so the patient presented an Adam-Stock syncope, and the third-degree IV block was the cause of Adam-Stock syncope. In this moment, the patient was referred to the cardiovascular surgery department, and a permanent pacemaker was implanted and saved the patient's life. In this moment, the most important question was in which context appeared this third-degree IV block at a young patient with this syncope Adam-Stocks, because it's really unusual at a young patient to be so severe diagnosis. A congenital cause is possible to take into discussion, and the cause of the congenital third-degree IV block at many patients, in fact, remain unknown. Another congenital cause has been linked to the presence of lupus in the mother. It is true that the maternal antibody may pass the placenta and attack the heart tissue during pregnancy period, but wasn't the situation of this patient because the mother didn't present this diagnosis of lupus. And another cause could be ischemia, but of course at a young patient it's really uncommon that ischemia to be the cause of the third-degree IV block. Everybody know that this is the common cause in adults patient, but sometimes rare also in young age it's possible. An inferior wall myocardial infarction may cause damage of the IV node, causing a third-degree heart block, and usually this is a transitory third-degree IV block, not permanent. And as well, an anterior wall myocardial infarction may damage the distal conduction system of the heart, causing the third-degree heart block permanent. The young patient didn't have an acute myocardial infarction because if everybody saw the ECG before, the image of ECG wasn't with an image of acute heart attack. In conclusion, an acute myocardial infarction may present with a third-degree IV block in the young, but wasn't the situation of this patient because the ECG appearance excluded this diagnosis. In the end, because the patient presents a few non-specific symptoms such as weakness, asthenia, and adynamia as well, for this reason, the patient performed a biopsy of deltoid muscle and showed increased variation in muscle fiber diameter in context of muscular dystrophy of Duchenne. In the next slide, we can see together the histopathologic examination of the young patient after the biopsy from the deltoid muscles was performed. And here, in this image, we have a few specific elements which we'll discuss immediately, which confirm the diagnosis of dystrophy muscular of Duchenne. The proportion of endomysial stroma was abnormally great in young patient and increased with the progression of the disease. And morphological disorganization of myotendinous insertion was associated with fat accumulation at this location. And the presence of these features in normal muscle should be considered in the diagnosis approval of biopsy specimens. Results and discussions. The disease, it's a rare genetic neurological disease. The cause of the third-degree IV block at this young patient was in context of this rare genetic neurologic disease, muscular dystrophy of Duchenne, confirmed safe by histopathological examination after muscular biopsy. In conclusion, at young patient with a third-degree IV block, we must to take into account also this rare but possible cause, muscular dystrophy of Duchenne. And why to don't recognize if the patient didn't perform a muscular biopsy, the cause of third-degree IV block remained undetectable and unknown. So this was my presentation for you. This is flower for everybody, and I want to thank you very much for your attention.